Hello and welcome everyone. My name is Renee Garrett and I'm your speech therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Megan Sutton is the owner and employee of Tactus Therapy Solutions Limited and co-author of Healing the Broken Brain and an instructor and affiliate for MedBridge Education. My financial disclosures are that I'm the owner, founder of Brainbridge Connect. Sorry, it's been a day. And I'm also an adjunct instructor for both James Madison University and Old Dominion University. Megan's non-financial disclosure is that she's a committee member of Aphasia Access, the Professional Advisory Council member of the National Aphasia Association, and clinical faculty at the University of British Columbia. Another note for Megan's financial disclosure is that she does receive an honorarium from Speech Therapy PD for her participation in the podcast. And switching back to my non-financial disclosure, I'm the secretary for the Communication Disorders Foundation of Virginia. So just to give you background on Megan, here's her bio. Megan Sutton is a speech-language pathologist and the co-founder and CEO of Tactus Therapy, a leader in speech therapy apps and creator of the new Virtual Rehab Center online software. She is the co-author of the book, Healing the Broken Brain After Stroke Recovery, and is an internationally invited speaker on the topics of aphasia and technology. Megan has worked clinically in a wide variety of healthcare settings, including an intensive aphasia program. She currently leads the Tactus Therapy team from her home outside of Vancouver, Canada. Welcome, Megan, and thank you so much for being with us.
Thanks so much for having me, Renee. I'm really excited to talk to you today.
Yeah, I'm excited to talk to you too. I know we've had this kind of in the works for a while now, so I'm grateful we can make it all work out. So let's start by finding out a little bit more about your background as far as why aphasia kind of became the area that you chose to work with, or even if you're comfortable talking about why you became a speech language pathologist.
Yeah, I was always interested in language. I had some early experiences with some um, kids who were using AAC, and I thought it was really interesting. And then I kind of got into linguistics in university. But it was really when I was taking a class and I saw a video of a person with aphasia for the first time. And I couldn't believe it. I couldn't believe that there was this like intelligent adult who couldn't get their words out. And it just seemed like heartbreaking to me. And I saw that video. I think it was a black and white video in a psychology class. And I was just like, wow, I need to help these people. Like it just called to me and I never looked back from there. I applied to grad school the next year and I went in and I worked in technology. I was working in the computer lab at Rutgers University. And I said, there's got to be a way technology could help people with aphasia. And at that time, I was thinking it was probably AAC related. But I went to Boston University, got my degree, started working with adults, worked in rehab, and absolutely loved it. Just loved doing the therapy. It was so great. I volunteered at aphasia camps and worked wherever I could with people with aphasia. And then it was in 2011, probably late 2010, that I saw the iPad. And I got one on my unit for the first time. And I was like, great, I'm going to download all the aphasia apps. And there just weren't very many. So
Right.
that's when I set to work. I partnered with my friend Ben, and we started Tactus Therapy, and we started creating apps to help people with aphasia get more practice.
Yeah, I
And
think at one point you do an aphasia cruise, weren't you a part of that? Or I think you might have done it a couple of times.
yeah, I was a volunteer with the Aphasia Recovery Connection, and they do
Yeah.
some cruises. So I went as a volunteer to help with their programming on board the ship, which was really great. And then in ports, going around to the islands and seeing things with people with aphasia. And that's where I was able to record a couple videos that I shared on YouTube that have been really powerful for aphasia awareness.
I use this full disclosure in my aphasia class this past semester in the spring, and I think it's helpful because the students get a lot of theory and foundational learning, and they don't really get that practical application that they really need until they go you know, kind of in clinic, but more so when they go out into the real world. So I thought it was really cool for them to be able to see that and get a better understanding of not every aphasia looks the same, right? Not every patient looks the same. Not everyone's the same age. The stroke can impact people differently. It could be, more of a TBI related aphasia as well. So I think that um, helps lead us into the next part, which is talking about aphasia and defining that from a medical perspective.
Yeah, you're right. It's so different for everyone. And, when we look at the medical definition, it's, neurological damage to the portions of the brain responsible for language production and processing. So we know that impacts talking and listening and reading and writing. And we often hear that it doesn't impact intelligence, which is important to notice, right? Like
Hmm.
we hear aphasia impacts language, not intellect. And that is true, but I want to get more onto that later because there's some nuance there. But in terms of the definition, aphasia is so much more than a language impairment to the people who
Hmm.
have it, right? And that's what you don't really understand until you start working with people and getting to know them and getting to see how the aphasia impacts their lives. So my favorite definition of aphasia comes from Dr. Nina Simmons-Mackey, who said, aphasia disrupts communication, the core of our ability to develop and maintain relationships, take part in home and community events, and project a public image of who we are. And I love that because it highlights that aphasia doesn't just impact our ability to interact with the world, but to really, it's our self-identity,
Hmm.
right? Like when we get to know each other, how do we do that? We talk, right?
Yeah.
I tell you what I've done, you tell me what you've done. We share our passions, we share our interests, and we find ways to connect. And if you can't speak or if you can't understand what's going on around you, you lose that connection to your life and to other people. And that leads to social isolation, it leads to depression. Um, it's just, there's so much that we can do as speech pathologists when we really engage in person-centered care and don't just treat the impairment, but treat the person.
Yeah, and I love that shift because for me, it's never really been a shift. I never felt like I was treating to the impairment, but I was treating to the strengths. And I continue to explain that across different practice settings to patients because when we're doing assessments, especially, what happens is they get super nervous anyway, right? A lot of people have test taking anxiety at baseline. And then when you say, hey, I'm going to do this assessment, they're like, whoa, well, I know I have trouble talking right now. And that really doesn't set people up to feel like they're going to be successful. So I always try to explain it that this is letting me know what you're good at and what you might need more help with. And I think that's one of the ways that sets people apart differently when they're looking at, like you said, that person-centered care and that personal impact that we can help with. A lot of times, I think clinicians that aren't really into I say into treating aphasia, but I've seen it. We had, in inpatient rehab, we had a couple clinicians that it just wasn't, they really like swallowing. They really didn't enjoy or get passionate about the language aspects, where I was the opposite. I was like, give me all of the TBI patients, give me all of the stroke patients. And it just, I think it's like a deep-seated thing. It clicks with you, it resonates with you, and you want to um, kind of change the world, right? That's kind
Yeah.
of how it feels when you feel empowered and you feel like, oh my gosh, maybe I can make a difference. Maybe I can help this person. And let's look at that. So, from an assessment standpoint, looking at how we impact that, how we kind of go into it, do you have words of wisdom on that or tips and techniques maybe that you have used in the past?
Well, yeah, my tips only come from my own failures, because I went to grad school over 20 years ago now, and my aphasia class was all psycholinguistic model of single word processing. Like it was boxes and arrows and all these, theoretical ways of how we process words through the semantic system and the graphemic output buffer and all the things that. And I went into my first aphasia patients and I'm like, I'm going to figure this out, right? I'm going to draw their box and arrow diagram. And I really didn't focus on the person because I wasn't taught that that was how aphasia care should happen. And I hope that's changing throughout grad schools now. And I know you're teaching differently, and a lot of the professors that I work with are definitely teaching differently because the life participation approach has really grown in that time. But for me, realizing, hold on, I don't necessarily have to start with an assessment. Uh,
Mhm.
Sometimes we do because of insurance requirements or because of our facilities that require that. But maybe I can get away with like a different kind of assessment, a patient-reported outcome measure, or something a little different that gives me that chance to build rapport with my patient instead of saying, "Hi, I'm your therapist. You're going to do a test now, and I'm going to make you really uncomfortable, and I'm going to make you do everything that you can't do well." You get to know the person first and
Mhm.
let them tell you what's wrong or let them show you what's wrong. And then exactly as you said, you use the test as a way of saying, what are your strengths? Where can I help? But you don't have to take the results of that test and develop a treatment plan from those results. And that's kind of, I think, what I was taught to do, or what I assumed you did, was whatever you
Mhm.
get wrong, you fix.
Mhm.
And that's probably not best practice. Definitely not best practice.
Yeah, but I mean, I can remember when I was in grad school that LPAA was being developed and communication partner training was really being worked on, and it was by people like Nina Simmons Mackey and Dr. Stacey Raymer. Um, you know, I'm tongue-tied now because I'm thinking about all these pioneers in the aphasia world and the things that they brought to the table and the way that it did change practice later on down the pike. And one thing I think that's really helpful too is talking about different kinds of assessment. I talked a lot to my students this semester about informal assessment. When I also worked in acute care for a very long time, and a lot of times in acute care settings, we don't always have access to standardized testing, nor do we have time to complete a 1 hour, 1.5 hour, 2 hour aphasia assessment. So we can use a lot of informal measures while sprinkling in some time breaks and um, tell me about your grandkids or tell me what your pet's name is or what do you do for a living? Are you okay if your spouse jumps in or your son's here today and they can help fill in the gaps so that I can get to know you because they know you better? Do you use any or have you used informal measures kind of like that or something different?
Oh, absolutely. Yeah. I mean, I always had the sort of, short forms of the formal assessments ready, but I would use those more in inpatient rehab. In acute care,
Mm-hmm.
it's really just about, that dynamic testing. I would always do diagnostic therapy, like jump
Mm-hmm.
right in with the therapy so you can help somebody, but
Yeah.
your diagnosis is based on how much help you provide.
Mm-hmm.
Right. So I'm going to help you do this thing you need to do, which in acute care might be call the nurse or fill out your menu or, whatever it is that is participating in life in an acute care hospital, those become the goals. And then I figure out how much to help. And in acute care, you don't have a lot of time usually with your language patients, right? You know that your job is to advocate for them to get to rehab,
Yeah.
because you have such a much bigger swallowing caseload usually in that setting. So just providing that information, providing written information so that the family can process it later, making sure that you get those referrals in and make sure that person gets the care that they need down the line.
Yeah. And again, I really think that sometimes when we think about staff that we work with our multidisciplinary team, a lot of them don't come into an acute care or even an inpatient rehab setting knowing what aphasia is, and that's another area of growth for us is to provide that kind of like it's like being the ambassador for aphasia or being the liaison for that patient, communicating with PT, communicating with nursing, communicating with the physician, because depending on where you're at, I mean, in acute care, not every physician has a really lengthy or strong neuro class. They may have done a little seminar on neuro and they don't really understand aphasia. They think it's all the same. Well, they just can't talk. Throw a
Exactly.
Wernicke's aphasia patient at a physician who's not versed with aphasia, and you really have them fooled. They'll be thinking, "Oh, that's all cognition. That's not Wernicke. I don't know what Wernicke's is. Explain it to me." And I always tell same with students. I tell them the same thing. Once you see that, you will know what it is because it's different from your, I feel like I always saw a lot more Broca's, more transcortical motor patients, those types of aphasias that were more like anterior and frontal versus I didn't get a Wernicke's aphasia patient every week.
Right.
It was kind
Yeah.
of few and far between.
They don't come along as often, and then they are usually up and walking around. They don't
Yeah.
always get to rehab because they don't always need the other therapy disciplines.
Mm-hmm.
So they do get overlooked a bit. So it's really important to find them. But you got into the neuroanatomy a little bit, so I'm going to jump on that. With so often, our aphasia patients are the left MCA, CBA, right?
Mm-hmm.
But I started noticing as I was a young clinician looking at those MRI reports, how many times basal ganglia was also mentioned
Mm-hmm.
in the CT or the MRI. And so that got me thinking like, okay, so aphasia is a loss of language, not intellect. But why are so many of my patients not able to do these simple tasks that aren't language related? And so I started looking into it more, and the basal ganglia are involved in a lot of cognition, right? So that same stroke that takes out the language center, Broca's area, Wernicke's area, or all that area that we think of as language, it does other damage too. It's not like this perfect isolated infarct, right? So
Mm-hmm.
especially in early rehab, we see a lot of people with aphasia who also have cognitive problems. And so I've been doing a lot of reading lately in the literature around cognition and aphasia. And while I think it's still so important that as a public awareness campaign, we advocate that people with aphasia are not intellectually impaired because they're not, early on as clinicians, we have to address these cognitive issues that we're seeing, or maybe that we're not seeing because we're not testing for it. So the literature is actually saying, like, a 2019 study said that 79% of participants with aphasia in their study also had executive function problems. There are other studies that show most people with aphasia have attention problems compared to
Mm-hmm.
people without brain damage. So if we aren't looking for these attention problems or we aren't looking for these executive function problems, then we aren't rehabbing them. We aren't focusing on them. And those things, along with working memory, really predict outcomes. So if you have attention problems, you have executive function problems, you have working memory problems, you're not going to do as well in rehab as people who don't have those troubles.
Mm-hmm.
So I'm trying to now, in with my technology and on the virtual rehab center, really find ways that we can make it easy for clinicians to look at cognition in the presence of aphasia and look at rehabbing that so that if we can get attention stronger or problem solving stronger, that's going to lead to better carryover, better strategy use, all kinds of things.
Mm-hmm. Well, one thing that I saw when I was an outpatient was I was getting a lot more patients who had, say, had had a stroke with aphasia 2 years prior, and now they're getting a dementia diagnosis. And it was hard, kind of hard because I wasn't in the same facility or the same building and not always had access to the talking to the neuropsychologist who did the testing. And a lot of times I'm wondering how much of that was test taking inability because of the aphasia, and then you just scored them as having that inaccuracy that led to this dementia diagnosis when maybe again that might not be what it is. It may be this memory piece and this attention piece because we know, kind of switching gears, but working with TBI patients, those things go hand in hand, right? And it's hard to have a memory of something if you can't attend to it. So there's a lot of like pieces and parts that are moving that are, we're connected in our brain this way, we're connected this way, we're connected that way. So you can't, you made a really great point about you can't separate this pinpointed, I had an infarct right here and that's it, the end. Because that's not how roads work. And that's how I kind of describe neural pathways to my students is think of all the roads we have all over the place. We have interstate highways, we have regular roads. We have here in the states, we have state highways, we have little country roads, we have roads in and out of our neighborhoods. So if any one of those roads is broken, or they're doing construct, we're doing a lot of construction here where I am. It's irritating. Every day it's irritating because it shouldn't take 10 minutes to get to the grocery store because it's right there 3 miles away. But if the road is um, closed or there's a detour, what happens? It takes us longer to get there, but we're still able to get there. And I think a lot of times for our aphasia patients, that's what we spend some time on is trying to figure out how do we reroute this to make it more efficient.
Yeah. Well, so I read a study recently that showed that working on working memory with people with
Hmm.
aphasia, nonverbal working memory, improved not only working memory tasks that weren't trained, but also language.
Hmm.
So we know that working memory is a critical part of being able to store and process and get our thoughts together for language. So this study was one, and I can give you the link for the show notes, but um, really recommended that working on working memory is best practice for aphasia rehab. And I'd
Hmm.
never heard that before. That wasn't really something on my radar. But the results were strong enough that I decided to prioritize putting a nonverbal working memory treatment into our software to make it easier for people to do this. Because if researchers are saying this is best practice and clinicians don't know about it, then I see it as my role in what I do with software development and with blogging and publishing information on the internet to make it easy for clinicians to find this information. Because I know that clinicians don't have time to be digging through all the journals and they hit paywalls everywhere they go. They want to do what's best for their patients, but we have to make it easy for them to do that.
Yeah, no, I agree. And I think going back again to that um, inner workings of the brain and how it all works together. If one part is impacted, and it makes total sense that you could have impairments in executive function, you could have impairments in um, kind of those because executive function is more complex tasks typically, right? It's really about a lot of it is doing more than one thing at one time. That's hard for a lot of people at baseline, right? So some people just aren't they aren't wired that way. It's some of that I think lends back to like theories of learning, whether you're a visual learner or you're more of an auditory learner, or you need a kind of a hybrid of both. If that's who you are before you have a stroke, that's really not going to change because you had a stroke. It may actually be um, kind of more prominent in what you're trying when you're trying to communicate or you're trying to complete a task. So what are some of the tasks you would say um, that are language based that maybe people aren't thinking about when we're thinking about our patients in, because you talked about this a little bit earlier, but patients in inpatient rehab or patients that are on like an aphasia cruise, or they, God forbid we were able to go back to doing community outings with our aphasia patients or any patient for that matter. But some of those things that maybe we should be looking at a little bit more that to kind of stand out to you.
Yeah, well, I think, we can set goals around whatever is important to the patient, right? So really working with them and not feeling like we have to be the decision maker in those situations, right? We help them explore their options, what they would like to do. I think, in outpatient therapy, especially, you can get some really good practical functional tasks to work on because people are out there living their lives and there are things that frustrate them. What I find frustrating as a clinician about that point of view is that when I'm working in inpatients and all my patients say is, I want to get back to normal, I want to get better, right? They don't have that perspective of being back in their lives yet to really know what they want to do. Sure, being able to order their favorite coffee is something they'd like, but that's not what they want to work on necessarily because they just want to get better. So I think working with people, trying to find something that they are motivated to achieve, something that looks like they are making progress to them.
Mm-hmm.
Uh, but then another really important point that I want to touch on is the importance of home practice.
Mm-hmm.
So what I love about using technology is that I can kind of outsource that repetition to the app or to the software. And so I get to spend my time with my patients doing really meaningful things and doing that motivational interviewing and finding out what matters to them and working on that role playing, however is best to achieve that. But they still do want to get better. They still want that. And we have a lot of research that shows that our aphasia treatments work.
Mm-hmm.
But the important thing about, or one very important thing about that aphasia research is that those studies usually deliver the therapy at a specific dosage or intensity that we can't achieve in
Mm-hmm.
our therapy schedule. So, the study that came out in 2022 was the RELEASE study on dosage, intensity, and frequency of language therapy. And the results were just amazing to me. Like they did this meta-analysis over 1,000 people, and they found that the greatest gains were seen between 20 and 50 hours of speech therapy. Now, for some people, we can achieve that. We can do 20 to 50, but for others, we can't. Their
Right.
insurance doesn't cover it. They don't have insurance. Our facilities restrict how often we see people. Um, so looking at the results of this study and knowing that like the best outcomes often come from like 9 or more hours of therapy a week. Like if you're looking at improving somebody's comprehension, it's like 5 days a week, 9 hours a week to even begin to see results.
Mm-hmm.
So if you talk to clinicians and they're like, oh yeah, I try working on auditory comprehension, but it never works. Well, guess what? It doesn't because you're not delivering it intensively enough. And that's
Yeah.
that's not your fault. You're not doing the wrong thing. You just aren't giving them enough. And even when we do therapy, like, are we really spending the whole hour doing auditory comprehension? Usually not, right? Like,
Mm-mm.
okay, never. Because that would just be kind of boring for us. It would be repetitive. But if we can use software, if we can use apps, if we can use technology to deliver that therapy when we don't have to be there, and the patient can do it 30 minutes at a time, a couple times a day, whenever they have the energy and are able to, then we can start to see better outcomes, not only on those very functional goals that we're working with them on, but also on general language improvement. And the cool thing about this is that these studies are usually done on people with chronic aphasia.
Mm-hmm.
But we know that people with chronic aphasia can improve. They just need the right dosage and intensity. So,
Yeah, and it's very similar to like if you're familiar with any of the Parkinson's programs, it's about a lot of it's about dosage and frequency. It's an outpatient's supposed to be set up for 4 days a week. There's no one in the planet, I don't think I've ever seen a patient 4 days a week in an outpatient setting because again, we're constrictions for what our facilities allow, and insurance, like you mentioned. And so a lot of that is home exercise practice, and it's again, that pacing. Similarly, we know that a lot of our patients do experience fatigue. Anytime you have a disruption in your brain, that's something that can happen. It's not their fault and it's nothing they can control. Um, I was actually reading something on stroke and postpartum women yesterday, and it was talking about how fatigue plays in, but also how they're sort of people are made to feel like the fatigue is their fault. Like you're just not sleeping well. You need to sleep better. You need to make an effort to sleep better. And it's like that's not it's not really realistic from if you're looking at like the pathology or the physiology point of view of what the patient has experienced. It's not like you can go, okay, I'm gonna go to sleep now. It doesn't work that way.
well, and it's not always about sleep too, right? Like neurofatigue is real. Like the
Hmm.
brain just gets tired and it can't do as much. So, I've started incorporating more of like spoon theory. Are you familiar with that?
Mm-mm.
Spoon
I
theory
don't
is,
think so.
oh, it's a kind of an analogy that was set up by someone with lupus. It's used a lot in chronic disease, and it's used a lot with TBI patients or concussion patients, where
Okay.
you've got like a set number of spoons for the day,
Yeah.
and brushing your teeth costs 1 spoon, and making breakfast is 2 spoons, and you have to, it's really an energy management approach.
Yeah, I have done that with TBI patients. We just did call it, it wasn't spoons. I think we did straws.
Yeah. And I mean, it doesn't have to be spoons. This is just what somebody came up with, and it kind of caught on. But I'd always seen that as like chronic disease management. And
Hmm.
aphasia is a chronic disease.
Hmm.
Stroke survivors experience this chronic fatigue a lot, for years after their stroke. And so teaching them ways of self-managing their energy is really helpful. And it's not something that I'd really attached to aphasia. I'd kind of segmented it into like, this is a cognitive thing. But it's not. They're all the same. Like we need to recognize too that aphasia has these same brain disruption symptoms. And
Hmm.
neurofatigue is a huge complaint from people with aphasia.
Yeah. Or and what else you get when you hear someone says, "Oh, well, you need to try working on your sleep or work sleeping better." A lot of our patients with aphasia have and TBI too have disrupted sleep because of what's happened to their brain. It's not, I don't know anybody who's going around going, "Oh, yeah, no, I don't like to sleep. I don't feel like I need to do that ever." No one does that.
No, and they have less ability to go to their doctor and clearly outline what their
Mhm.
problems are. So they're probably less likely to get any medication or any referrals to help them. And the same goes for depression, right? Mental
Mhm.
health is a huge issue in aphasia for the reasons, I talked about with social isolation and self-esteem coming from communication. But when you're then feeling down and you can't communicate, the last thing you want to do is schedule an appointment with your doctor and go in and explain exactly how you're feeling because you can't.
Right. Yeah, and both of those things also make it more difficult to communicate. So even if the patient has made, some significant progress in their therapy, if they have that uh, fatigue, whether it's physical or cognitive or both, and then they have this also the depressive symptoms and feelings, both of those things make it more difficult for the average everyday person to communicate. Of course, it's going to impact communication in our patients with aphasia.
Yeah. And the basal ganglia that I mentioned before, are involved in motivation, right?
Yeah.
And play a role in depression. So, it's just so complicated, right? It's not these simple box and arrow diagrams that I learned, and that's aphasia. We're dealing with complex human beings with a range of healthcare symptoms. Some of those things may have been their lifestyle, which led to the stroke. Uh,
Hmm.
and others, just the stroke causes them. It's out of nowhere, right? There's so many reasons or lack of reasons that people have a stroke now. Um, but yeah, we're dealing with complex human beings, and I think as speech pathologists who are kind of, we put ourselves in a bit of a box, that's not always doing our patients the best service because their language isn't in a box for us to
Oh,
fit.
that's a book quote. That's really good. I mean, that's really to me very profound because it's you definitely did it. You get a different perspective when you're trying to teach graduate students about aphasia and trying to explain to them if they haven't had that personal experience. Because for me, my dad had aphasia, so it was a little bit different experience. I came into the field having a different mindset of what aphasia looked like for our family. Um, and it definitely changes your perspective, but that's not something you can always teach students. They really need to be able to see it, feel it, embrace it, kind of try to figure it out based on their own learning. And I think when they can see all of these pieces and parts and all these components that are complex, it helps them gain a little bit more understanding that no one is going to their doctor and asking for aphasia. right? Hey, can I get a prescription for aphasia? Or my health literacy is poor, or my access to care is poor, and this has already set me up for cardiovascular disease that may lead to a stroke. No one's going to the doctor like, hey, I want a stroke. I, I, the box thing really resonated with me because I think there are a lot of people who still think in that box modality, and they're not looking at the brain as being in charge of every other thing in your body. Right. I think for so many years, and I've said this so many times on the podcast and different webinars I've done, but for so many years, people thought the heart was really what controlled everything. That's sort of like the community thought, and it's not really based in anything. I think it's just how people assume that the heart does all this stuff, but really it's the brain who's doing all the things. It's telling everybody else what to do. So if it's interrupted, we can see, and we know this from working with stroke patients, we can see difficulty with bowel, bladder, incontinence. You can see that AFib that's new. You can see other issues that come up with kidney function and all sorts of things that can be impacted. So I think we really have to start looking at patients holistically more across our field and not just, a handful of clinicians or a handful of researchers who are kind of disconnected from the practicing clinicians too. And I think we're trying to move in those spaces and develop ways where it's all connected because we for so long have been like over here and I'm doing this and you're doing research, and I don't know how that applies to what I'm doing because like you mentioned, a lot of that research is really it's gatekeeping is what it is. It's being behind a paywall and not having access to it for years. And I think that makes it really challenging. But and I'll tell you my favorite aphasia treatment that I don't know why I love this. I love semantic feature analysis so much. And I don't know if it stems back to I did cross category generalization as my thesis in grad school. I don't know if it goes back to that um, or not, but I love I love that treatment for some reason. I just find that uh, there's so many ways that you can use it. And it typically is well received by patients across the lifespan and across ethnicities and race and gender and all that kind of stuff. So, what's your favorite treatment methodology, or do you have more than one?
Yeah, no, that's interesting. Semantic feature analysis. I think it just makes sense because it's a treatment by like, activating all those connections, but it can also be used as a strategy, right? Like it's kind of practice for circumlocution, and it's something
Yeah.
that we do naturally anyway, right? Like, oh, that thing, it's brown and it's, in the living room, and like we describe things to kind of play those word games anyway. So that is not my favorite treatment, though it is a good one. Um, I would say that my favorite treatment, and it's not quite a treatment, so this is cheating, so I'll give you another one after this. But I think the most powerful treatment we have in our toolbox is conversation partner training.
Yeah,
And
I would
and
agree with that.
but I think it's the one that we don't use enough as a profession because we're so focused on the impairment and the patient themselves that those partners are the ones who are there to support them. So if you haven't trained the communication partner who's living at home or living in the same space with that person, they're not going to have conversations. They're not going to get to practice. They're not going to get intensity and repetition of anything else because they don't know how to talk to each other.
Hmm.
So I'm a big fan of communication partner training. Typically use the Aphasia Institute's protocol. Um, that Ora Kagan published. But, I think anytime you get those partners involved, teach them strategies, teach them awareness of each other and how to help. Keywording, big Sharpie on white paper. Um, as much as I love technology, when it comes to conversation partner training, I'm all about paper and pen. I don't want a whiteboard or anything that I can erase because having those artifacts of the words that were in the conversation gives the person with aphasia the chance to go back and refer to something else or raise questions. So, yeah, that's where I lose my environmental streak It's just use as much paper as you can. Uh, but really figure out what works for that person. So after you've trained communication partners, and I think as a speech pathologist working in a hospital, your job is to train staff as
Yeah.
communication partners, train the nurses, train the doctors if you can get them, train, the PTs and OTs. Um, so that's a really good way to make a difference there. But then training, the loved ones of the person with aphasia for sure. In terms of like nitty-gritty treatment protocols, my favorite ones are probably VNest and
Yeah.
Orla.
Oh, yeah.
Those are the two I've seen the most success with. And I think it's because they kind of work at the sentence level and
Hmm.
they are more complex and they are multimodal, like you're reading, you're writing, you're speaking. Um, and so those are kind of my go-tos for that mid-level aphasia.
So just to tell people that are listening who maybe, because I do have a lot of people who listen who are school-based or retired, if they're not necessarily familiar, can you tell us what VNest is? And then tell us also what, or I know what it is, but I want other people to know what it is too.
Yeah, so VNest is verb network strengthening treatment. Um, Lisa Edmonds developed it. There's been lots of research on it, but the idea is that you start with the verb.
Hmm.
And like that semantic network of semantic feature analysis, this is using the semantic network of a verb where you're figuring out what subjects go with the verb and what patients or objects go with the verb. So you take a verb like drive and you come up with a sentence of who can drive what, so like Mary drives a car or the
Hmm.
bus driver drives the school bus. And you come up with three different pairs of who can drive what. And then you expand the sentence, you read it aloud. And so you're really focusing on the verb. So I've got a blog post on my website that goes through all the steps. And we built that into our advanced naming therapy app just as a way of making it more accessible to clinicians. And I have to say, I'm not claiming all credit because there's tons of research and tutorials and great things out there, but the number of clinicians I meet who were introduced to VNest through the app is really rewarding because now they have access to this evidence-based treatment that they didn't know about because it was in a journal or, something that they hadn't heard about. But they see it in the app and they can easily do it. They can assign it for home practice and they're seeing their patients get better.
Yeah, or a lot of times too, what happens is maybe they heard about Venus in grad school, or maybe they read parts of the article, but they don't know how to implement it. And I think that's a huge piece, which is kind of what you were alluding to. But that for me was what I saw with like CFs and students. That was huge for them because they'd heard about what it was, but they didn't know how to do it. They didn't know how to implement it, and they didn't see it's that lack of knowledge and implementation science part of it where they might have this foundational knowledge, but then it's like, what do you do with that? And as a brand new clinician, that's hard. We're expected to know so much about so many things and do all these other tasks, attend meetings and do all this other stuff, and it's hard to kind of implement something when you've only read about it and never saw it in practice or didn't understand how to make it part of your repertoire. Um,
Absolutely. And, that's with everything. I think you go on YouTube looking for examples of treatments, and what you find are a lot of graduate school projects of student clinicians doing these treatments with other students. And what we really
mhm.
need to see is real examples of patients. Um, but not even having, the step by step is kind of what led me to want to write my how-to series on my website, was that I didn't even know these treatments existed, let alone how to do them. And so when I
Mhm.
went to a course back in, I think, 2008 or 9, and I learned about these treatment protocols, I was like, wow, I've not been doing any of this. I've just been doing worksheets, right? Like that's what was in my therapy room was all these workbooks. So that's what I did. And then I was like, wow, this is powerful. And I put it into practice the next week and saw immediate progress in my patients. So I was like, well, if I didn't know about it, there's somebody else out there who didn't know about it. So I wanted to share that information with the field. And yeah, and so that's been a really positive way of getting that information out there. putting it online for free, putting it in apps to make it easy, and now we're putting it on the virtual rehab center.
Yeah. And let's backtrack a little bit and kind of talk us through Orla. Tell us what that stands for, that acronym stands for, and the general overview of how we use that.
Yeah, Orla is one of those treatments I learned about in that course that I was telling you about. It stands for Oral Reading for Language and Aphasia, something
Hmm.
like that, from Dr. Leora Cherney. And Orla is really just reading out loud, but in a very systematic way where you take sentences of a certain grade level and length and read them in unison with your patient, or read them first and then read them in unison, and then have the patient read them and point to some of the words that you call out to make sure they know which word is which. And um, and then building on that. And the amazing thing about the research for Orla, let me see if I get this right. The For severe patients, doing Orla improves their reading. For moderate
Hmm.
patients, it improves their talking. And for mild patients, it improves their writing. You don't even work on writing in Orla, but it has that transfer effect, right? 'Cause
Yeah.
they're reading more words and then they can write better. So it's just powerful. I think both of those treatments being at the sentence level kind of uses that complexity account of therapy that if you work on something harder, the easier stuff fills in. So if we work on sentences, words kind of fill in. We don't have to direct all of our treatment at the word level.
Yeah. And another one I love is script training. And I was talking to a student about that because they have on their final exam, I had a case study, and part of that was writing up SMART goals. And because I know they're learning it in clinic, and I don't donate a ton of time to it, but I wanted them to be able to integrate all this information that you're learning in all these spaces and make it make sense to you, and take that with you when you go on to the next thing. And so one student's long-term goal for, I think she said it for 6 weeks, was memorization and utilization of 15 scripts. And I was like, oh no. How about we start with three, maybe five, 3 to 5? That would be good. But yeah, again, it's that hearing it, thinking it sounds cool, but not knowing how to uh, implement it in a practical way. Because again, we have to go all the way back to the beginning of what's important to the patient. Maybe they don't want to order food. Maybe they're not going back to work. Maybe they're not in these scenarios where they're going to be doing a scripted thing. Maybe they're not going to call and make their doctor's appointment. Maybe they can do it on their phone. Maybe their loved one wants to do it and they want to take charge of that. It's really all those things you have to take into consideration when you're doing things like goal setting, because it's not a one size fits all.
No, not at all. And I've always had a bit of a pet peeve around the word functional because we use the word functional a lot. And it is often thought of as like, oh, well, I can call my doctor and make an appointment, or I can convey my food order. But isn't it also functional that we can have a fun conversation with a friend? Like,
Participate in a book club, something.
yeah, like just to call up a friend and be able to complain about how you're feeling, or to talk about something in your family. Like that's what we use communication for a lot as social beings. We are social beings, and communication is how we connect with each other. So I think we discount the importance of just being able to, you know, get things off of our chest or to brag about something or like there's a lot that we use language for that doesn't have a function except that it makes us feel better because we feel like a human being.
Yeah, and I probably use that word a lot, but I think of it in terms of what's functional for you in inpatient rehab. You need to communicate with this person, and this person, or then you go into the next setting, and sometimes that next setting is the community. It might be home. Maybe your home now is different because financially, maybe you had to move to something smaller to be able to afford it if you can't go back to work. And again, it's just thinking about all those things. And I don't think we come out of school with that base knowledge
Not
of
at all.
what we need to be effective to help our patients make improvements and demonstrate those outcomes. What are some of your favorite patient-reported outcome measures?
Um, oh, I I haven't been using, I know there's a lot of good ones, so I'm
There's
not
a
the best
lot of
person.
new ones, so I'm
Yes.
I'm not real good at it either.
And that's it. I don't know all the new ones. Like I probably have a database somewhere of them that I can look up. But because I've been focused more on the technology development side, um, I just love that we can ask people something before treatment and ask them after, right? Like it doesn't have to be that formal of a measure. And so that's one of the things that I've been really keen on lately is just self-awareness and self-rating scales. Because I think that comes in, you can put that into any treatment. Like, how hard do you think this is going to be for you? How hard was it? Were you right? Why didn't these numbers match up? Or good, you've got good awareness. Um, I know we're talking about aphasia, but I think, self-rating in dysarthria is huge, right? To know, was I clear? Did people understand me? So just using any kind of predict your performance or rate your performance scale is, I know it's not quite a patient-reported outcome measure, but you can turn it into that, right? If you collect enough data. So maybe that just that it doesn't have to be a published one. There's tons of great ones out there. Um, the ones I've used are good for helping with goal setting, like the
Mm-hmm.
study or the communication something inventory, CBIS, something like that.
Is it communicative participation item bank?
CPIB, yes, that's the one.
Yes, the 10 question.
Yeah, that's a really good one to help with goal setting and for outcomes to see how far people have come.
Yeah, and I would say probably the aphasia impact questionnaire is probably pretty popular one. And I know I have a colleague with every patient with aphasia, she does a pre and post treatment communication confidence rating. The communication confidence rating scale for aphasia, she does that one a lot. And I would say that's probably one that's more well known. Um,
That's huge. You know what, that's one I've come around on so much is that, I didn't really think about treating confidence or having goals around confidence earlier
mhm,
on. And then looking at this whole human being in front of me that I'm treating and realizing how important confidence is.
mhm,
To get out and practice, to get out and participate in your life. Like confidence, you can have somebody with the most minor impairment, but if they have no confidence, their lifestyle looks like somebody who's severely impaired.
mhm.
And so we can address confidence. We can set goals around improving confidence and showing people that they should be more confident and helping them get there. And that was something that, wasn't covered in my graduate training, wasn't something I was prepared to do. And so I I do love that sometimes um, speech therapy sessions you can feel like a life coach. You can kind of
Mhm.
catch yourself feeling, am I outside my scope? Like what's going on here? But it's all in the interest of helping that person communicate and participate in their lives.
Well, and I think one of the best ways of doing that is when we have our own moments of disfluency or we lose our train, as people like to say, or we're in the middle of talking about something and you get distracted by something. I think when your patient sees that happen to you, they're like, it does address some confidence issues because they're like, oh, well, you're not infallible either. So here we are. And I just saw you totally misstep in your attempt to communicate, and it makes us more human because that's
It,
really what it's about. Like you said several times, the human connection and um, taking ourselves off the pedestal. Um,
and that's why group therapy is invaluable, right? Like it's one thing for us to make a mistake. We're, not impaired in the way they are, but when you see people with aphasia in a group,
hmm
and they start, they're noticing, oh, that guy's worse off than me. This woman does a little better. Like they're comparing themselves to everyone, but they're so supportive of each other. Like
Yeah.
when a person with aphasia meets another person with aphasia, it is just that instant connection of, I know what you're going through and I'm
Hmm.
here for you. And that is magical. And that's what I saw on the cruises, and that's what I've seen in the group therapy that I've done. Um, and I think we need to prioritize getting people into groups because that is where magic happens. In the realm of confidence, in the realm of getting that identity back and making new friends because a lot of friends disappear because, well, we can't chat on the phone for hours anymore. You don't go on hikes anymore. So you lose those things in common. So people with aphasia need to find new friends, and other stroke survivors are great for that.
Yeah, and I know there's a lot of research to support that, but what I'm seeing is a lot of clinicians who are going out on their own into private practices are incorporating nonprofits who support aphasia projects or aphasia group camps and things like that in the summer, or like a winter break camp. We say camp, we think 6 weeks, right? But sometimes it's like they come for, it's almost like the inpatient rehab model where they come for an hour a day or they come for 4 hours a week or whatever it is, and they're able to again see someone else has this too. Maybe I can help them. Maybe they can learn how to cue me or help me with a strategy that worked for them. And it's really, really beneficial for the patients, but I think it's a light bulb moment for clinicians when you haven't seen that before.
Absolutely. And I think we're making good strides as a field of including people with aphasia more in research design. We're including people with aphasia more in product design,
Mm-hmm.
um, in education, and having people with aphasia teach students what it's like to have aphasia and involving them in the classrooms. So the more we can empower them by bringing them into our work, we're going to produce better work that better serves their needs.
Yeah, I agree. So just as we're wrapping up, is there any last thoughts, conclusions, remarks, anything we missed today that you wanted to cover?
I think that's most of it. You know, I I'm busy now with, developing new things and with my team and writing some new series on our blog. So, realizing that just a couple of how-to posts isn't quite enough, we're delving now into like this series of what SLPs need to know about different things, about awareness, about agraphia, about alexia. So it's just an exciting time for me because I'm getting to dig into the research and really figure out what's out there and what's changed in recent years. Um, so yeah, I'm excited about the future of aphasia therapy and really grateful that you had me on to talk about it.
Yeah, well, I'm a fan. Um, I really just appreciate the work that you're doing, and it's to me, and I feel like it's pioneering, really. It's been crucial in my practice, but like you said, it helped me connect the dots in some areas. So I really want to say thank you for making things free on your website because that's really helpful, especially when we are in a space where a lot of our employers no longer reimburse things like tuition or conferences and things like that that we don't get funding for anymore. So whenever we can have validated, evidence-based research that's accessible and we can use it pretty quickly in our practices, I think is really, really, really important and really helpful.
Well, yeah, you're most welcome. I am here to help people with aphasia and clinicians, to not make the same mistakes I've made and to advance practice and make it better. And I just happen to be doing that through a business, because that's just what works for me. But yeah, really appreciate that. Clinicians are always giving me feedback, and I try and respond to that, and I welcome any of that feedback, and I'm happy to do the work of digging into things and sharing it with you.
Well, thank you so much, Megan, for joining us. Again, I really appreciate the work that you've done and the things that you're continuing to do, and that you're so willing to share your information and, really, really empower us that are, in the field. And some people are struggling and some people are thriving. And I think either on either side of the coin, it's cool that we have access to this. So thank you. And just as a reminder, If your state license requires you to complete CEUs, complete all course modules before the end of the day on your speech therapy PD account. Again, thank you so much, Megan, and we look forward to seeing you.
Thanks, Renee.